So I am going to now turn this over to and introduce you to Kevin Simon from Boston's Children and the City of Boston. He'll be talking about a presentation dedicated to health equity and behavioral health. Dr. Simon is the inaugural Chief Behavioral Officer, Health Officer for the City of Boston, appointed by Mayor Michelle Wu. Through the Boston Public Health Commission, he will guide a public health strategy to support Boston's growing mental health and behavioral health needs.
Thank you. Hello. We're just waiting for... Okay. All right. So we're going to talk about health equity and behavioral health, as Secretary Sutters just mentioned. And I am Dr. Simon. Thank you, Jackie, for highlighting me. In terms of disclosures, I don't have any financial disclosures. However, I do have many emotional disclosures. And I likely will also walk up and down, as I don't like to just stand in one place. And so you shouldn't know me other than the role I'm in. So I want to tell you about myself and why this is important to me. So I'll start with my parents. They are from Haiti, and my mom's from Gonaïves. That's the capital. Well, the capital is Port-au-Prince. Gonaïves is the central place of the revolution. And if you met my mother, you'd understand why people from Gonaïves would lead that. My dad is from Cap-Haïtien or Bas-Saint-Blair. And in 68, 69, they opted to move to Flatbush, Brooklyn, New York. They didn't know each other at the time. And then they had me. And before me, they had my sisters. And we tend to stand in the same orientation all the time. And my dad is a Roman Catholic deacon. He happens to also be a teacher, taught in New York City public schools for over 25 years, and then transitioned to doing social work. And my sisters are nurses. So that's my nuclear family I grew up with. This is my new family now. So that's Brittany, or Dr. Brittany Halper. She's a hospitalist at BI. And then to her left, that's Brooke, who's 4, going on 24. And then on the right, that's KJ. He's a year and a half. And so it's important to share about me, in part because undoubtedly there's some connection that we all kind of have. And I think when we engage with youth, it's important to try to think about what are the ways that we actually can connect. So if you're not of Haitian descent, you might be a brother or a sister or a dad, right? So there's always something to connect to when we have our engagements with patients. This busy slide is just some of the other more career connections that I've had. So went to Morgan State, that's an HBCU in Baltimore, migrated to the Midwest, to Illinois for med school, Grady Hospital, which is equivalent to BMC for adult training. I came up here to Boston Children's. So I share this also, again, there's some connection undoubtedly in this room that we have. NIH funding, so someone could call me a physician scientist. I do like data. Health policy is important, so that's where the Commonwealth comes into play. And so things like the 1115 waiver I get excited about. So again, there's connections that we have here. And I've done a lot of moonlighting at a lot of hospitals, some of the state facilities like Tewksbury, et cetera. So again, I'm just sharing to provide connection point, and also to provide some levity before we actually talk about disparities, which are not funny. So these are the things that I am, but I actually would just identify myself as a learner, and so I'm going to share some of the things that I've learned over the course of time. And KJ is telling me that the clock is moving. Yes. So we're going to talk about narratives and evidence with regards to children of color and what that looks like in the behavioral health sphere. And we'll talk about that simultaneously. We're going to then highlight what the normative experience at least is suggested to be happening, right? And then think about how can we reimagine, now that we have certain policies in place, how to make things more equitable. So we will start with books that I like. So Rage of Innocence is about juvenile justice. Push Out is about Black girls getting pushed out of traditional society. And then Between the World and Me by Ta-Nehisi Coates. I'm gonna start with a quote from the book. "I'm not a cynic. I love you and I love the world. And I love it more with every new inch I discover. But you are a Black boy and you must be responsible for your body in a way that other boys cannot know." So Ta-Nehisi is writing to his son throughout this memoir. And this is actually a very classical thing for authors of color to do. You can think about James Baldwin wrote a letter to his nephew. So let's look at youth of color and education, so, where it begins. So Stolen Innocence, this was out of California. A large survey was done with persons in the community that might engage with youth. And evidence it suggested was that by age 5, right, so my daughter's 4, KJ's 1.5, by age 5, youth of color tend not to be seen as like kids who are soft and jovial and are adultified, sometimes by up to 5 years. Now, this is really important because suppose you had a 10-year-old who society perceives as 15, and depending on what happens, like, hey, let me have your ID, and you're 10, you're like, I didn't have an ID when I was 10. Now imagine the conversation, but let's say he's coming from basketball practice. Hey, where's your ID? I don't have an ID. That small frame, that small interaction could be perceived as appropriate or inappropriate, right? And if it's inappropriate, is this kid jazzing me? Is he being rigid? Is he not being cooperative? Actually, he could be being cooperative, and just the fact that you ask him for an ID, he doesn't have an ID, right? Because most 10-year-olds don't walk around with an ID. So this is important because, again, we have to think about the context of where this could happen. So let's keep moving forward. They suggested that this would work. So school disciplinary disparities. ABCD study is the largest study currently looking at youth, and they looked, let's just see. They asked over 11,000 parents of kids 9 and 10 just about the last year of disciplinary action, expulsion, in school, out of school. And what happens, 5% of children had a disciplinary action. So yes, you don't want a large percent of kids having disciplinary action. However, within that 5%, you guys think about, well, who is this more likely to happen to, right? And so it says, of the 5.4% who received a detention or suspension, controlling for typical predictors of behavior, Black and multiracial Black children had up to 3 times greater odds of receiving detention or suspension than white children. But I can tell you, having engaged with a lot of kids, Black, brown, purple, yellow, all really kind of behave the same, right? And so it begs the question, well, how come if the person maybe has hues of melanin, they're more likely to receive detention? And again, across neurodevelopmental spectrum, and I've seen this clinically, if a youth is of color, the bend is towards, punitive behavior rather than like clinical intervention. So at school, early on, another quote, I feared not just the violence of this world, But the rules designed to protect you from it. The rules that would have you contort your body to adjust the block, and contort again to be taken seriously by colleagues, and contort yet again, so not to give the police a reason. So this is the idea of code switching. For those of you who watch Fresh Prince of Bel-Air, this is why he had the pizza box while he was walking through, because he didn't want his cool friends to think that he was studying, so there was books in the pizza box. When we think about youth of color and broken systems, so there's going to be an image. This is the question, what do you see? This is where participatory engagement, you can say anything, just shout, okay? What do you see? What do you see? Head, hair, M, kid. What else? Fill in the visual for you. School, in a classroom, yes. So you do see an M, and because we're not on a high HD screen, what you may not notice, let's just make sure. What you may not notice is the M should actually be like cleared out, in part because yes, if I got a haircut and I want you to see the M, I clear it out. The M is not cleared out. So this youth, now imagine this, I got a haircut, Kevin and I went to the barber on a Saturday thinking we're gonna look good on Monday. Haircut, look fresh, I think I look fresh. And I get to school and I'm told that's not part of school dress code. So, and this happened unfortunately to a 13-year-old, the school official, two people, opted to take a marker and color in the M. Now, when I say, what do you see, I also try to get people to think about the whole picture, right? So someone said school. So now imagine I am this kid who thinks I look good, I'm gonna see Susie, and now I'm told nope, and they drew in, right, they didn't call my mom, they didn't call my dad, drew in this hair and a marker, right? Technically that's assault. Now, suppose you are this kid, and you gotta keep coming back to this classroom, right? Supposedly to have space to also learn calculus, English, whatever it is. So could you imagine that this kid becomes the one who is not engaged in class, in part because yes, when I came and I thought I looked really good, you told me no, I did not look really good. So all of a sudden he's not, quote unquote, emotionally invested in his learning. But is that actually true, right? Or is it the environment has not helped him to be invested, right? So oftentimes we will get these referrals, behavioral dysregulation. I say, yeah, I get that, but tell me the whole picture, right? Because I can tell you, it'd be very hard for me to come to an environment where every day I know you don't think that I belong here. So anyone know who this is? No, you shouldn't. He's used to live in Michigan. However, he is Cornelius Fredericks, and he is 16. And Cornelius, this is actually taken in, inside of a behavioral organization, residential, and he was physically restrained. So, question for you, was he being physically aggressive, cursing the milieu staff, throwing food, or threatening a peer? What do you think? Engagement. Cursing at the milieu staff. Okay. So he was not cursing at the milieu staff. He was in the cafeteria throwing food. I told you he's 16 in a behavioral health organization. Kids throw food, right? In normal development around this age, you're supposed to be testing your boundaries. So he was not cursing his staff. Now, how long do you think he was restrained?
4 hours, 2 hours,
An hour? No, not that long. 10 minutes. So it's interesting. I said 4 hours, or someone said 4 hours. I said 10 minutes. He said, oh, so 10 minutes is short? Long. Right. So again, context is important, right? Because you said 4, I said 10. You're like, oh, okay, it's 10. It's a long time. So he died. So this is why I had to kind of introduce myself earlier. So, physical restraint. Colleagues from Yale looked at over 500,000 ED visits. And so, when I said I'm emotionally invested, this tends to happen at this time within the presentation. So, over 500,000 visits in a very a very small percent of people have to be physically restrained. It shouldn't happen, right? So 0.1, this is national representation. Yet, again, when we looked at that 0.1, what was it? It was 36%, 39% were Black, 20% were Hispanic, 36% white, and they're aged 10 to 16, male, publicly insured, right? Of the 532 visits, 80% included a child presenting with a behavioral health problem. Right? So, again, the question is, well, you've kind of behaved the same. How come it's overrepresentation for certain youth to receive physical restraint? Now, remember that first slide, or one of the earlier slides, in terms of the adultification. And I've seen this, unfortunately, in the hospitals. Dr. Simon, we got a kid, really dysregulated. She's 14-year-old Black female. I said, okay, go to my chart. And I look, I said, 14-year-old. I don't see any 14-year-olds in the ED. And I'm like, what's her name? They tell me the name. I look, and I look at the top right. I'm like, no, she's 12. She's not 14, right? So we will behave with people in a certain way when we perceive that they should be behaving to us in a certain way, right? And if we think, as the evidence would suggest, that certain kids of color tend to be adultified, perhaps we're too aggressive at times. And again, I've seen this clinically, the evidence suggests it. So that's physical restraint. Same thing happens pharmacologically over, well, nearly 400,000 visits. And again, characteristics associated with pharmacological restraint, which happens 3.5% of the time. And so yes, the theory is that pharmacological restraint is milder, softer than physical restraint, so it should happen a little bit more. Yet, again, characteristics associated with that restraint use were late adolescent, 18 to 21, male, Black race, non-Latino, public insurance, and yes, you would have been admitted to the hospital. So it begs the question, why does this keep happening to people who are of a certain hue? And so both of these contexts, mind you, are in environments where trained staff, right, all went to nursing school, graduate school, medical school, something. yet it's happening, right? So it's not the bad actors or a bad facility. It's over 300 visits, over 500,000 visits, right? This is happening in our institutions. There's no one's good, no one's bad. We're just all really operating in a not great system. So, are we seeing the whole picture? Black people love their children with a kind of obsession. You're all we have. You come to us endangered. Youth of color and mental health, what I say is a beautiful struggle. So, diagnostic delays. And I picked this just because I know John Constantino, he's at WashU. And this is also the importance of, John does not look like me, but John is highly invested in the idea of equity. And it's the importance of individuals who maybe don't look like the patients that are having these disparities doing the work is just that important. So they looked at over 584 African-American children with autism. And this is also suggests it wasn't that only the child is African-American, it could be adoptee, so it could be interracial, because this next line that I'm going to say. So there's an average age of diagnosis of 64.9 months. And on average, 42.3 months, so about a year and a half, a couple of years, after parents' first concern. So again, think about this. I'm a parent, I got a kiddo who's not necessarily socially engaged with his other classmates or her other classmates, and I come, I'm gonna pick on Amara because she's not a physician, and I say, Dr. Amara, Kevin is just not seemingly engaged the way he should be. And so now think about this. Long wait list, right? At certain institutions, over 18 months for neurodevelopmental eval. And if it's a child of color, the concern that the parent is bringing is seemingly not addressed for several years, right? And I've seen this. See, kiddo, 8 years old, multiple dysregulation, being removed from school, coming to the AD, we send him back because it's not meeting the correct level of care. And I see him, I'm like, interesting. Yes, he's running around the office. Yes, he's very chaotic, but then he fixated on something that he really liked. And then I get on the floor, I'm like, hey, buddy. Hey, do you see me? And it's like I'm not even there, right? Because what can happen for children that have certain conditions, they can get really fixated and everything else is zones out. It's like, oh, I think he has autism. And you don't need a neuropsych report to get the diagnosis. It's clinical. And he's 8. I'm like, this is unusual. It's really not unusual. But it's like, why is 8 years old? How many years of services did he not get? So delays happen more often for youth of color, all up and down our behavioral health spectrum. So now let's talk about suicide. So these kids are pretty young, and in terms of the number, so 3.5 per 1 million. This is over a decade, so you can do the calculation. There's around 140 families that lost somebody. And so the question is like, well, wait a minute, 5 to 11, suicide, how's that happening? So don't click yet. And if I asked this well-educated audience of behavioral health enthusiasts, what is the method in which youth this young are not surviving? Anyone? Guns and strangulation. So we do tend to think about firearms and medication, but yes, they're 5 to 11. So next. Oh, one back. Oh, next. Forward. 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 Yes. So yes, so hanging and suffocation. Because again, what do these kids have access to? Their bed sheet, their shirt, right? So this is important, and I tell well, not but the fellows that train where I work, it's like when you hear them say certain things, your ears should perk up. So youth that overdose on medication often tell somebody, I took Tylenol, right? And they get to the hospital, and they get to our ICU, right? And so we perceive it that, oh, kids are taking medication. Certainly, and yes, we should lock up the medications. And then we think about the fact that there are firearms, but it's really the kids that don't tell anybody that's who we're losing. And I've unfortunately engaged many youth who, yes, lost a life of hanging, or parents had to abort them from doing that by bringing them down. So when you hear certain things, that should perk your ear. And the trend is not getting any better in this new decade that we looked at. And so now, the first was 5 to 11. Now we're seeing it in a little bit of the, I guess, moderate adolescent, 15 to 17, and particularly black girls. So yet more emphasis should be paid to certain youth with regards to our interventions. All my life, I heard people tell their black boys and girls to be twice as good, which is to say, accept half as much. These words would be spoken with a veneer of religious nobility, as though they evidenced some unspoken quality, some undetected courage, when in fact, all they evidenced was the gun to our head and hand in our pocket. This is how they steal our softness. This is how they steal our smile, our right to smile. So, healing strategies. It is possible to heal. And yes, we should be thinking about equity, but then justice, right? Because yes, I can give a kiddo more services, but I have to take a step back and say, wait a minute, why is it that this is the way that it is? And so I think this is where we have really good opportunity, particularly with the 1115 waiver and how funds can be distributed to certain types of organizations that are doing this really good work, and it's okay, you can come sit. We have to really make an investment into thinking about like the whole system and not just looking at the Band-Aid that we can often do. And so this is where this room is really important, because you all are a part of the system, right? And so current status quo is not really good, which is why some people are like, why would you want to take this position? It's like, well, current status quo is horrible. If we do something even incrementally better, it's going in the right direction. So in thinking about what would be needed in systems, what would be needed in funding, right? Although this is what I do with patients one-to-one, we can think that this can actually happen not only in a clinical space, because we already know that there aren't enough social workers and psychiatrists and psychologists, right? So how do we make the environment that people live in have an opportunity for them to be affirmed and acknowledged? creating a space for whoever they are, right? Racial storytelling, validation, the process of naming, external devaluation, countering that, re-challenging rage, if that exists. And I'll give a personal example. My daughter's 4. A month and a half ago, we started her in dance. She really didn't want to go week 1. I'm like, but Brooke, mommy brought the leotard, the tap dance shoes. Come on, let's go. Daddy, no, I really want to sleep. Like, come on, Brooke. I'm like, oh, what do you want to get after we go? It's like lollipop. It's okay, we could do that. And she goes to the dance studio. Week 1, awesome, she loves it. Week 2, she's enthused. Week 3, Daddy, I'm ready to go. And she's waking me up. I'm like, oh, okay, got it. And if I ask that dance studio, do you know you do behavioral health? They're like, what are you talking about? We do dance. But no, I'm like, you are a group of engaged adults who validate little girls of color and make them feel seen, right? And so when we think about funding, right, what is it that we should be funding? Yes, we should be funding clinical, but we already know there aren't enough clinical persons. We're all at the max, right? But what are the organizations that we can be thinking about that do the protective or preventive, right, mental health? Because the kids that see Chase or me, when we say, hey, what are you doing after school? It's nothing. What are you doing during the summer? Nothing, right? But imagine if we funded community agencies and organizations to be able to do this work, to gather more students, right? Maybe they wouldn't be showing up to ED, right? Because they'd have space and opportunity to express themselves. So I think this is what we have to be thinking about. And even as new units get designed, right, it always fascinates me. It's like a new unit. And then they'll show me like the play area, and it's like, they can come out here for 15 minutes for fresh air. Like, what? That's not normal, right? The play area should be the largest space. It should be green. Oftentimes, it's literally a blacktop, and they'll put a basketball hoop and say, this is where they can go. So I think we have an opportunity to really change the dynamics about what behavioral health looks like for Massachusetts. I'm particularly focused on the city of Boston, but our youth travel everywhere, right? So, gotta finish on something nice. And there's proof, my patients show me, my family show me, that we can do good work. So, Dr. Simon, hope all is well with you and your family, sharing an update on, I took his name out. He's crushing it. Thank you for helping save my son. He's had a great few weeks because you're amazing. Thank you, Mom. You can probably guess because he's home a little bit more pleasant, less stress, etc., working on it. Hope you're well. Colleagues are saying kiddos like me. Thank you so much for your support this week. Truly invaluable. This is a school teacher reaching out to parent. I hope that you all had a nice February, vacation week. Wanted to quickly touch base. I know you're tracking. The week has been extremely well. Overall, working hard, regulated, right? So this is, I tell fellows, if you just do good work, good can happen to our patients, and it will reach very far places. So, good morning, Dr. Simon. Came across your name. I was looking for an African-American therapist for my blank-year-old son. This is a family that across the world. So you have the issue here, but it's literally global. So we have opportunity to really make a difference. And that's what he was doing. So, thank you for your engagement.